Welcome back, everybody, to another Friday RLR version 7 a.m. Pacific time. It's a delight to be here yet again for many, many reasons, but we have the return to the case presenter seat of the one and only Yusuf. You guys probably, Yusuf needs no introduction on VMR, but I think it's absolutely incredible somehow that as a third-year resident in the middle of residencies, he's able to join VMR more than maybe anybody else under the sun. So, Yusuf, please say hi, but also you got to tell us your secret. How do you make this happen?
Hi everyone, so honored to be here. I only do it because of a lot of dedication, and I try to ask everyone around me to be excused during that time to join these sessions. And everybody appreciates that I'm taking time away just to learn, and they want me to do that.
Oh my gosh, you're too kind. That's amazing. So you're just like you're just telling people, and they as to no surprise at Emory supporting you to make sure you get here. Well, that's really really cool.
Well,
Rez.
only a code blue would take Yusuf away from that microphone. Otherwise, the patient can wait.
All right, Yusuf. Well, we're ready whenever you are.
Yeah. This is a 62-year-old male presenting for fevers and chills. I'm gonna give you just a little bit more history there. Uh, This is a 62-year-old male with past medical history of lupus, complicated by end-stage renal disease, which required a renal transplant years prior to this presentation, about 6 years prior. Unfortunately, this was complicated by graft failure, and they were continued on tacrolimus and prednisone to prevent further rejection. He also has a history of an aortic valve replacement that was mechanical and is on Coumadin, and a history of bladder cancer treated with a transurethral resection with intravesicular BCG 3 years prior. He's presenting for fevers, chills, and rigors, and I'm gonna stop right there.
Yusuf, soon I thought you were gonna say he also had replacement of his left knee. He had, sorry, I shouldn't joke around like that, but it's so many transplants, replacements, etc. But very let's get serious and so show some compassion.
Rafraz is feeling giddy this Friday. I love it. I love it. It's back
Robin,
to his teenage
you
years.
should be the one discussing, not me. I've gone rogue, man. Unhindered, but I will be I'll be brief here and like share with you honestly how I would be attesting my note, because as an attending physician, when I come to the VA, the residents do all the hard work overnight. I get to come in the morning with my Dunkin' Donut coffee and literally just look at charts, look at labs, and judge the work that was done the night before. And I've learned, Robbie, over the years, not to judge, because initially I used to get like angry, like, why didn't you send that? Why did you say that? But not anymore. I'm like, it's so tough when you do those night shifts and you're admitting people. But I think what I'll do is, in this patient, the one-liner is going to be quite complicated, and you're going to be biased based on what you include in the frame. So the best way to approach such a case is to step back and say, remove all the past medical history and everything that was done to this patient. Let's say we had none of that information. How would we approach fevers, chills, and rigors? And when you take that frame, immediately you're worried about bacteremia. Immediately. You see, fevers and chills just mean inflammation, whether it's bacterial, viral, or non-infectious in nature. But once you throw in rigors, it really increases the likelihood that you have some form of bacteremia. And rigors is different than shakes. Like, this patient is literally trying to increase the temperature of the body to meet the new temperature set point that's been raised by the cytokines due to whatever process is driving this. So whenever you see rigors, you should get blood cultures. And then with fevers, you really want to localize symptoms and signs to try to understand where the site of pathology might be. And the way to do that is you can just think about the most common sites of infection: the lung, the skin and soft tissue, the urinary tract, the GI, the liver, and bacteremia. You know, Rabih created that schema years ago, and I can't wait to present him some cases on RLR because Rabih, because of your schema, I've never been, I'm not even lying, because of your schema, the efficiency of arriving at a diagnosis was instant. It was crazy. Like, it was wild, man. So it tells you the power of a framework. So of course, Yusuf is going to give us that information, but now let's incorporate the background data. And actually, rather, because I've been talking for a long time, so Rabih, I took the frame of just fevers, chills, and rigors. Now with this background data, how does that shape how you're thinking about? And of course, common is common, but we have to be ready to attack the uncommon.
Yeah, 100%. No, I completely agree with you. I think the background data is profoundly important here. And I think it's actually still, for me, a little bit overwhelming to try to simplify what happens to the big categories of inflammation with infection, malignancy, autoimmune, and drug. What happens to that category when you layer on the patient has a transplanted organ and is on immunosuppression? And I'll just speak big picture because, of course, that's not the only relevant history. We have to study the fact that this person has a valve and this person has gotten other treatments as well. But if you're just saying, how does IMADE change when there's a transplanted organ on immunosuppression? You'll get phenomenal teaching from ID experts like Dr. Fadki, who's here. But I'll pass on the premise that has stuck with me as a generalist, which is that the kinds of infections you have to entertain are a function of the time and the distance between the acquisition of the infection and the transplant. And the general behavior is this: you get nosocomial infections immediately after transplant, surgical site infections, C. diff. You then start to really accumulate the immunosuppression related complications months later. And then years down the line, you start behaving a little bit more like a regular old person and are more and more vulnerable to community-acquired infections. But as is true in real life, these things are general rules. Early on, nosocomial; in the middle, immunosuppression related. And then if you survive long enough to make it years, months after your transplant, you just become not quite like a regular person. But if you've lasted months and months and years without getting an immunosuppression related complication, you're probably not going to get one. So that's the timeline. There's a very unique set of infection related mechanisms that happen in transplant patients, which is unique to transplantation, which is that you can get an infection from the transplanted organ. And that usually occurs in the sort of immunosuppression related period. So how does infection change in a transplanted patient? It's very important to get a sense of when the infection is happening in the setting of the transplant. And that timeline gives you a prediction of whether you're dealing with a nosocomial, immunosuppression acquired, or community-related infection. And then you have a whole completely novel, unexistent category, which is that you have a donor-derived infection, which doesn't occur in any kind of scenario. That's the infection category. What's different about the autoimmune category? The only thing that's different is that the person, if they've been transplanted for an autoimmune disease, you have to think about disease recurrence. And now you've introduced a whole new nidus of autoimmunity, which is rejection of the organ that was transplanted. So infections change in two ways: the type of infection in relation to time, and then the nature of acquisition of donor-related infections. The autoimmune conditions change in two ways: recurrence of the native disease if they were transplanted for an autoimmune condition, and rejection, which is fundamentally the definition of a immune attack. And then how do cancers change? There's a really, really important, completely novel set of cancers that occur in the context of a transplant-related immunosuppression called PTLD, or post-transplant lymphoproliferative disease, and a whole variety of other cancers that occur at much higher rates in transplanted patients, namely skin cancers, but also unique cancers like Kaposi sarcoma. So there's all sorts of immunosuppression-related malignancies. But honestly, the D, the drugs, is really important to think about, because the immunosuppressive medications can not only mess up the immune system, causing all these complications, they're also associated with a lot of idiosyncratic hypersensitivity reactions, with tacrolimus and its association with a MAHA being important to recognize. So big picture, this is overwhelming. And this is why there are experts in transplant-related complications, because you can see how big picture, it's just 2 examples in each category. Timeline related to infection, donor-derived infection, recurrence of native disease, rejection, PTLD, and many other transplant-related malignancies, and drugs. It takes a lot of people to sort this out. So this is going to be a lot of work, Prof. Rez. But curiously enough, the work's already been done by Yusuf and his colleagues. We just get to sit here and muse on it.
Amazing discussion. So this patient was hospitalized, and blood cultures were collected, and 2 out of the 2 cultures returned positive for strep sanguinis. The patient was continued on antibiotics, but which are ceftriaxone, and despite that was having high-grade fevers daily to 39.5. So this is where I saw the patient as with the ID consult team, with the master clinician, that is Dr. Fatke, and Dr. Abdullah, who's the fellow, is also on this call. So to give you a little bit of further history, the patient reported a mild cough with no sputum production, reported this is chronic. Review of system was in general negative. He denied any runny nose, sore throat, nausea, vomiting, abdominal pain, denied dyspnea, rashes, dysuria. He does report some night sweats while having the fevers. And as a background, so his home meds are prednisone, 10 milligrams daily, tacrolimus, 1 milligram daily, warfarin, 5 milligrams daily, and nifedipine. The past medical history, as I said, is for SLE, complicated by renal transplant, complicated by rejection, and he's now on dialysis via a left AV graft. The history of bladder cancer status post-TRP and BCG therapy, and aortic valve replacement. No history of other hardware anywhere else in the body. Family history was non-contributory. As social history, he works at a store, does not have any pets at home, no recent travel or hiking. He's originally from the southern United States. He has lived abroad maybe just for a few years in Europe in the 90s, was in Belgium. He's never been homeless, never been in prison. He never worked in a prison, was never a sex worker, no sick contacts, and no medication allergies, and no other health-related behaviors.
Prof. Rez, I rambled so much that I think we need to balance the rambles with some actual medicine. Take it away, my
You know
friend.
what I was thinking about? There was like something on Twitter where they're like, when you consult ID, and sorry, Dr. Patke, when you consult ID, they'll be the ones to acquire the information to the patient and give mouth to mouth to a rabbit. I was just looking at Yusuf's social history. Apparently this actually happened, and like ID, but in any case, we're not judging people on RLR at 7 a.m. PST. But with regard to the information, look how powerful the rigors was. We were suspicious of bacteremia, and we took a base rate approach. But it was really important to exercise that Rabih went through, because the mind is primed, if things don't go as expected, to lean into the less common scenarios. And recently, I was on service, and I'm actually not going to share this story because I'm presenting it to Rabih, but whenever you get blood cultures that are positive, this is your first question. Are they true, like pathogenic, or are they a contaminant? And so how do we make that distinction? There are multiple ways. One, is the number of blood cultures that are positive. So if you have, for example, 1 out of 4, maybe that's a contaminant. 2 is the time to positivity. So if I get blood cultures and 2 minutes later it's positive, you better be cautious by dismissing those blood cultures. And 3rd is the type of organism. So like if it's gram negative, you always have to take that seriously. Now, if it's gram positive, it depends on what the organism is and who the host is. Because some organisms like Staph epi, you might dismiss in most comers. But even if Yusuf told me that this was Staph epi, I would still take it seriously. Why? Because of the host that we're dealing with. Now the frame is really important. An immunocompromised host with a mechanical valve receiving dialysis through an AV fistula. This is critical because the question becomes, is it true or is it a contaminant? This is true bacteremia, both the organism, the number of blood cultures, and the patient. Now, the question becomes, why are they still febrile? Because strep species are so sensitive to the 3rd generation cephalospore and ceftriaxone. It can be one of 2 things. Either, and most likely, that the source of the bacteremia has not been controlled, meaning that you can put on antibiotics, but if you don't control the source of the infection, you're going to continue to have positive blood cultures. So in a patient like this, it's really important to do daily blood cultures to see if you've cleared the bacteremia. Then the second scenario, which I think is less likely in this patient, is it another etiology, at least at this time point 0? The next most important question, once you go through the branch of contaminant real, is where did it come from? And I was actually on GPT-4 right now, and I just typed in strep sanguinis, and it's part of the oral cavity and oral mucosa, and it can cause bacteremia, it can cause endocarditis. But in general, bacteria come from mucosal surfaces, the GI tract, the urinary tract, the respiratory tract, the oropharyngeal space. In this guy with the valve, you now have to get an echo of that valve for sure, TTE. And if you don't identify a source, you might even consider it TEE, because some valves, especially the valves of the right side of the heart, which are anteriorly located, those can be seen well in the TTE, but the posterior ones can't. So you might have to do a transesophageal echo. Then other sites that bacteria love to hide in is the bone, like the vertebra, where there's degeneration. They love anything that's degenerated, and vessels. And so with that fistula or graft, could that now be infected? So you have to examine this patient so closely and be open to multiple metastatic sites of infection. And now what we need to do, Yusuf, is we need an echocardiogram. We need to analyze the AV fistula. We need to repeat blood cultures. And then we need ID on board, which you are, to see, like, do we need to do dual antimicrobial for this patient? One last comment I'll make. It's really cool. At our VA, when we get blood cultures that show organisms that are positive, like gram positive, or it reflexes to BioFire, and BioFire has a set number of organisms, like the most common culprits. And like within that very day, we have a suggested organism, whether it's Staph aureus, Staph epi, or one of the Enterobacteriaceae. But let me pass the mic to Robbie to see what additional thoughts he has, like reflexively, that ED doctor that he is, how he's approaching this.
Yeah, no, I mean, I nothing to add, Prof. Rez. I think that's absolutely superb. I think folks may wonder, because you corrected yourself. It didn't say fistula, it said graft. I think that is a small teaching point. The fistula, the difference between AV fistula and AV graft is that the fistula actually uses native vasculature to connect the artery and the vein. Graft is when you use prosthetic material to connect the artery and vein, so further increase the risk that this is a nidus of infection. So it's no different than the patient having a prosthetic valve. So that's a nuance that you notice Prof. Rez say deliberately, and the graft is just more high risk than the fistula.
Or inadvertently, but thank you for making that teaching point. I didn't even make that distinction. Maybe subconsciously I did, but superb, Robbie. Thank you.
I think your subconscious reigns supreme, Prof. Rez.
Okay, let me give you the first set of data. I'm going to give a little bit extra data than the exam just to give you more to work with. So the patient was febrile to 39.1 with a heart rate of 110, with a blood pressure of 150/80. He was just uncomfortable because of the fever, and otherwise was not in distress. He was resting in bed. He was on room air. His exam, his lungs were clear on auscultation. On auscultation of the heart, it was just the mechanical heart click. His left AV graft was not particularly tender or warm. You could feel the thrill, but not particularly like significant on our exam. And otherwise, the exam was non-contributory. We palpated all of the spinal processes, and we looked in the oral cavity and did not find any abnormalities on exam. And to give you the first set of labs and imaging, so the white count was 17,000, which was 75% neutrophils, 0% EOs, lymphocytes were 18%, which is within normal range. The hemoglobin was 8.7 with an MCV of 81. The platelets were 300. The baseline hemoglobin was around 9.5, I would say. Otherwise, on his sodium was 136. The potassium chloride bicarb were within normal range. His BUN was 31, and his creatinine was 6.3. Other labs, so his AST was 107. His ALT was 89. His ALK-Phos was 213. The ESR was elevated at 69. The CRP was elevated at 106. Complement levels were within normal limit. Double-stranded DNA was within normal limit. Repeat blood cultures ×4 were negative. And to give you the final data, I know this is a lot, the TTE and the TEE did not show any vegetations.
Professor, I'll just take the exam and then pass you the mic for the labs. I think that you might be most alarmed if you're really stick to the fact that you don't have any subsequent data in the exam and don't have the labs and the TTE to tell you. I'm really curious for you all to try to participate as much as you can in this question, just like we did yesterday, to really get as much learning out of it. So my question to you is, in the next 10 to 15 seconds, try to decide and write in the chat, just to commit to it, which of the 3 vital signs that we have here has you most worried? Is it the temperature of 39.1? Is it the heart rate of 110? Or is it the blood pressure of 150/80? And again, pretend like you're getting this data, like you walked in the room, there's no labs. Which of those 3 is most alarming to you? We'll give it like 10. And I'm just curious what the total from. Okay, so Kareem is saying the temp, Nikita temp, promise tachycardia, high grade fevers. So mostly the temperature so far. Temperature, tachycardia. All right, lovely people, you're going to hate me, but I think it's the blood pressure. And let me tell you why. One is your sneak peek into me telling you that asking you this question is that it's unusual, just like yesterday. So when you hear that the patient has a aortic valve, you have to always be wondering about the possibility that they have some sort of complication of their valve, the most feared of which is aortic insufficiency, aortic regurgitation. So what does that have to do with what we're talking about? What we're talking about is having an approach and thinking about a wide pulse pressure. The first is, well, what does it mean to have a wide pulse pressure? And actually, there's the conflicting definitions in the literature. The first definition is that the diastolic blood pressure is less than half the systolic blood pressure, which here, based on my extremely good math skills, is not quite the case. Another definition in the literature is that the diastolic blood pressure is more than 60 below the systolic blood pressure. So either this is borderline wide or it is truly wide. Now here's fun fact number 2. Fun fact number 2 is the manual cuff, which was probably used, grossly exaggerates the diastolic blood pressure, especially in patients with aortic insufficiency. The pathophysiology of that requires dissecting how manual blood pressure's cuff works, so you can look it up. So here, if you're even borderline thinking the patient has a wide pulse pressure, you should think about the fact that it might be even worse than it actually is. So in a patient who is inflamed and you have a wide pulse pressure, especially if they have a valve, you really have to think about the possibility of aortic regurgitation. The good news is that hypothesis doesn't pan out and with the TTE and TEE, but that's not what your operating hypothesis should be. The diagnosis that often accounts for wide pulse pressure is atherosclerotic stiffness of the aorta as a result of age, but also this patient's end-stage renal disease no doubt contributed to that. So I'm very glad that that wide pulse pressure did not pan out to the hypothesis that the valve is overtly involved. But I would argue that at time point 0, in a patient who is inflamed, and you see that pulse pressure, that should really, really grab your attention and for you to pursue that hypothesis with a lot of vigor. So yes, the fever is important, the tachycardia is important, but I think a wide pulse pressure that turned out to be benign would have been the thing that really grabbed my attention. But I'm very glad that that it didn't. Prof. Rez, other thoughts?
I love when you share your teasers, Robbie. So for the rest of the data, the white blood cell count is not surprising. We have a neutrophilia and eosinopenia from underlying cortisol secretion in the context of the inflammatory process. The hemoglobin of 8.7, that's not surprising either. We know this patient has end-stage renal disease, has low epogen production, and is going to be anemic and maybe even iron deficient. And then you add to that inflammation, but you just pause momentarily because you see that the AST is out of proportion to the ALT. So you wonder, could there be an extrahepatic cause of hemolysis? I think not, but since I'm entertaining that, I'm going to get a peripheral smear. I would consider an LDH and a haptoglobin. Then we have a TT and a TEE with nothing going on with that valve. No paravalvular abscess, no vegetation. And so now we got to step back and frame it as such. A immunocompromised patient, and if you were, like, honestly, if you were an ID doctor or an advanced clinician, you would include the type of immunosuppression because that influences the type of infection. But we'll just leave it at this because I'm neither an ID doctor nor an advanced clinician. 62-year-old guy, immunocompromised, history of lupus complicated by end-stage renal disease, status post transplant, complicated by failure of that transplant with an AV graft, here with strep sanguinis, bacteremia, and despite appropriate antibiotics, continues to have fever. So then you ask the question, if someone is bacteremic and you give them appropriate antibiotics, when would you expect their fever to resolve? When would you expect their white blood cell count to respond? Because that's going to dictate what we do next. Like, why are they chasing everything if we're like, we examine the valves, he's febrile, we're done. Why do we need to do more? Well, no, we're not done. Because typically, and I don't have enough experience with different types of organisms, but in general, when you start targeting the right organism for bacteremia, you see an immediate response. Like, you'll see the white count come down the next day. You'll see the fever subside. Maybe it comes up a little bit, goes down. But this, where you're persistently febrile, and I bet we're on hospital day 3, 4, 5 with the ceftriaxone because he's already got the transesophageal echo. Now you got to step back and say, wait a minute. Am I dealing with a source that I've yet to identify that's, causing this infection? The only disconnect there is that he's not persistently, I'm assuming the blood cultures have been negative, the repeat blood cultures, or are you dealing with another process? So for this patient, rather than say we're done, the echo is negative, you got to be like, no, wait a minute. There's something going on here that's causing this patient to be persistently inflamed. What other tests can I do to make progress on my diagnosis? And this is the other test that I would do in this patient. In addition to the smear and the stuff that we talked about, we need cross-sectional imaging. And I wanted, like, I would get it of the chest, abdomen, and pelvis. And I would just, at RVA, PET CTs are easier to do because the PET CT will also tell you what's going on with that graph. Like, is it lighting up? Is it not? You know, so my next step, Robbie and Yusuf, would be a PET CT whole body because of the lack of expected response to antibiotics if this was a simple bacteremia without a source that we never identified. Later on, I would love to hear from Barun, like what percentage of these cases we never find like an actual site and we just treat for 2 weeks with antibiotics. But that's where I'm at with this right now, Yusuf.
Yeah, thank you both so much. So like you both said, we next started thinking about the AV graft as a possible nidus, despite the repeat cultures that are negative, just to evaluate that as the source. We got initially an ultrasound, which just showed some mild soft tissue edema. The vascular surgery colleagues were consulted, and they were actually like not impressed with it, and they did not think that there was like any source infection at that site. In the next couple of days, like you mentioned, so the patient was persistently febrile, daily to close to 39, mostly in the AM, but was treated with Tylenol, and that was subsiding, but persistently with high-grade fevers, persistently on antibiotics, and repeat cultures were all negative. So to give you additional information, the patient was receiving dialysis as well throughout this time. The hemoglobin had a slight drop, like 6.1. He necessitated transfusions times 2. We got a further workup. The TSH was within normal limits. A CMV PCR was undetectable. A toxoplasma IgG and IgM were negative. A Bartonella, Brucella, Coxiella serologies were negative. HIV was negative. Adenovirus PCR was within normal range. EBV PCR was positive at 2,900. A lipid panel showed a cholesterol of 120, triglycerides of 368, a LDL of 97. Given like this, the haptoglobin was undetectable, the LDH was elevated. A smear did not show any schistocytes or any signs of hemolysis. A ferritin was 12,100, and a interleukin-2 receptor was markedly elevated at 47,000. And I'm going to stop right there.
Thank you so much, Yusuf. Can I just ask one question? How high was the LDH? Do you know?
I don't have the number, actually.
Okay, no, that's okay. And the only reason I asked that is because LDH is a poor person's test of lymphoproliferative disorders. And so if it's very, very high, you really got to start thinking about the lymphoproliferative diseases. And maybe what I'll tackle is just, I'll briefly talk about the lab abnormalities and pass the mic to Robbie, but the high IL-2, the high ferritin, the inflamed state, it all makes you wonder, does this patient have hemophagocytic lymphohistiocytosis? Generally, that diagnosis you think about when you actually have bicytopenia as opposed to a single cytopenia, meaning that this patient has a leukocytosis, normal platelet count, and has an anemia that can be from a number of causes. It seems like they're hemolyzing because they don't have cirrhosis, so I'd expect them to have a normal haptoglobin, and the fact that the haptoglobin is low and the AST is out of proportion to ALT, it seems that there is some hemolysis that is smear negative. So it does prompt a Coombs test, and he does have a history of autoimmune hemolytic anemia. So his immune system could be revved up. He could be releasing IgG, leading to opsonization of those red cells and subsequent hemolysis. But HLH is a possibility here. And what you can do is the H score. And I'd love to hear Robbie's thought on whether he thinks that this patient has HLH. And if you do arrive at that diagnosis, then the question becomes why? And the most likely etiologies are lupus, mononucleosis and lymphoma. And so I'd love to pass the mic to Rabih, and I still want cross-sectional imaging of the chest out just to see if there's some lymphadenopathy or something else that's driving this inflamed state.
You're 100%. Prof. Rez, I'm glad we get to talk about HLH, because the truth is that what HLH is just another form of a kind of inflammation. And you saw Yusuf very deliberately tell us the differential with the patient not having eosinophils or basophils. But what HLH fundamentally is, it's a pattern of the body's response to an external trigger. And how is that pattern helpful? It's helpful just like eosinophilia is helpful in that it changes the differential diagnosis. So what does HLH do? It's a pattern of response. And in many people, that pattern of response is abnormal genetically, and they get this abnormal response to even mosquito bites, actually can get this pattern of response and die from it. Just like eosinophils can kill you from the myocardial endovascular damage they do. So I think what has emerged is Yusuf is building a case that this phenotypic response of this person to this disease process is macrophage predominant. And all we know now is macrophages are reacting vigorously by producing a lot of IL-2 or contributing to the production of IL-2 and by contributing to the production of ferritin. So this for me is just like, oh, Yusuf is just telling me the diff of this inflammation. And I think the key question, as you said, Prof. Rez, is what is the significance of the EBV? And the EBV, if you are blind to the quantitative PCR and you know it's positive, there's two ways that EBV can be related to this. The first is that there's infection-derived HLH, which is actually one of the most common forms of HLH triggered in young people, is acute mononucleosis. However, when the EBV is high in the context of an older adult and the context of HLH, it's much more likely that it's representative of an EBV-driven lymphoma. However, just like the vital signs, I don't think any of those hypotheses are really true because of the titer of the EBV PCR. It's very, very low. So how can you explain that? You can explain that by EBV being so reactive to anything going on in the body and often reactivates in low levels. So I think the question is, does this person have, what are the common triggers for HLH? And you said them. Does this person have lymphoma? It's very, very possible. Does this person have lupus? I think that possibility has been made lower by Yusuf's very deliberate presentation of the dsDNA, the ANA, and the complements, which were all normal, therefore dramatically reducing the possibility that this is lupus triggering HLH. So I think the tension is always going to be there. Is this infection driving HLH, or is this PTLD, or the lymphoma that would be diagnosed after transplant? The EBV PCR is an outstanding test for PTLD in one context, and that context is if you have PTLD within the first year of transplant. The risk of PTLD in patients after transplant never goes to zero, but diminishes with every year. And the other thing that changes is their EBV positivity. So they go from having a very high chance of being EBV driven to actually the majority being EBV independent PTLD. So PTLD is totally fair game here. And I think, Prof. Rez, your query for cross-sectional imaging is going to be money here. But I think the focus of the conversation is, wait, why am I thinking about lymphoma when the patient has a fever of 39.1 and a neutrophilic predominance? And I think that, for me, really puts the onus on us trying to figure out what infection is driving this HLH phenotypic response. And there's three kinds of them, really. Actually, for simplicity, I'll just tell you that there's two kinds of them. There's the mononucleosis-driven infections, which we talked about why they're less likely here. So for me, this case is all about right now hunting for the granulomatous kinds of infections that this person is at risk for. So that's the exercise for me. And guess what? We're literally injecting him with a granulomatous infection. Yeah, that BCG that he's getting for his bladder cancer. So I think that becomes suspect number one now, is bladder cancer induced BCG, which is disseminated. And when you look at that alk-phos, you're like, ooh, is it in the liver? So, Prof. Rez, I'm really worried about a granulomatous infection because I think this is HLH-y. And I think while lymphoma is an important consideration, the neutrophilic predominance and the hectic febrile presentation would make that a little bit less likely. And I think it's all about what kind of granulomatous infection this person has. And a close review of his epidemiology is important, but we're giving him one. So I really hope that's not it. But I would worry a lot about that right now. Yeah.
Yeah, thank
Sure.
you both. I loved hearing about the HLH flavor of infections / malignancies. That's really, really good to hear. So I'm going to give you some more information. The LDH was 500. Hematology was consulted, and like you both said, they were like, continue your workup, see if we can find a secondary cause of this HLH. Regarding imaging, they initially got a chest X-ray that was clear, a ultrasound of the right upper quadrant, which just showed hepatomegaly. Initially there was a tagged white blood cell scan to evaluate, which is vascular surgery's preferred modality to evaluate the left AV graft. It did not show any active infection in the left AV graft. We unfortunately then had to proceed to PET-CT, like you both requested. The PET-CT showed increased uptake adjacent to the right hip within the iliopsoas muscle, concerning for abscess. Multiple FDG-avid pulmonary nodules in the left upper lobe and the right lower lobe, and then diffuse uptake in the dependent lower lobes. And I'm going to stop right there.
Prof. Rez, I rambled again. I think we should hear some magic.
Bro, you never ramble. Your poetry. I think that such an interesting case, Yusuf. Thank you for bringing this. And the question becomes, it's like so interesting when you had that disconnect between the blood cultures and the persistent febrile state. It really, I think, prompts you to step back and reconsider the driver of the underlying inflammation. And whenever you get a positive study, you have to apply the law of proportionality. Could this abscess that was detected in the iliopsoas muscle be explaining all of this patient's presentation? Highly doubt it. Highly, highly doubt it, because one small abscess is not going to cause a persistent febrile inflammatory state. And furthermore, we have other abnormal imaging findings that we must explain. Whenever something is FDG avid, it just means it's metabolically active. FDG avidity cannot tell you if you're dealing with an infection, a cancerous process, that they're active. They're using the glucose and it's sliding up on the scan. Now, when you see nodules that are active in the lungs, it's really helpful to frame those nodules as, scattered or miliary, perilymphatic, or centrilobular. And this is giving you more of that miliary pattern. And that's really important, folks, because if you were worried, for example, for miliary TB, it notoriously is so difficult to culture because the organisms are actually not in the parenchyma. They're not in the alveoli. They're like in the blood vessels. So there's no connection. So you can sample as much as you want. You might not have a positive TB. You know what I love about this case as I'm discussing, this is like an honest reflection, is I know Varun is here, and like Varun is like one of the best IT doctors. It'd be so interesting to do a fact check on all the comments we're making to see what percent is actually accurate. But nevertheless, I think with the lung nodules and the avidity in the lung, now you wonder, do you have an infection or a cancer that is pulmonotropic? Pulmonotropic. Is it tropism for the lung? The thing that makes cancer less likely here, honestly, because if it were cancer, where is the cancer? Like, to have just like these small nodules in lung, yeah, you can have primary pulmonary lymphoma, fair game. But to have like a solid cancer somewhere or a lymphoma, intravascular lymphoma, fair game. But I just think infection, to Rabih's point, is prioritized. And now the tempo and the fact that the patient's on antibiotics takes us away from the common culprits and really prioritizes those granulomatous infections. And this is where the history is really important. Like, where does the patient live? Because the granulomas, when you think about infectious etiologies, are primarily mycobacterial, non-tuberculous mycobacterial, endemic mycoses, like fungal infections. And the BCG, I actually have a BCG vaccine. I think it's only about like, I don't even think it's that effective. I got the BCG vaccine and then I converted positive on a PPD. Then I went on isoniazid, developed hepatotoxicity, but it was temporary. My primary care doctor prescribed me pyridium instead of pyridoxine. I had orange urine. Then I went off and fired that primary care doctor, completed the isoniazid to reduce my risk of reactivation of TB to less than 1%. But Robbie, I think, that hypothesis of BCG dissemination, literally mycobacterial dissemination, is a good one. And so where do we go? I think we want to sample what's in the parenchyma and maybe biopsy if we can't actually acquire anything. But Mike to Robbie to further add to that.
I've never seen somebody discuss medicine so eloquently and talk about firing their primary care doctor in one single breath. You didn't even breathe. I have nothing to add. I think that's mastery right there. Storytelling in medicine at its finest.
Yeah. So the patient underwent bronchoscopy with BAL. The bacterial, fungal, and cultures were negative. AFB was like no growth to date. Biopsy of the nodules with cytology was without malignancy. There was sampling of the right hip as well with bacterial, fungal cultures, all negative. All antigen tests for fungal tests were also negative. AFB was no growth to date. The patient at this point in time is hospitalized and having daily fevers. I was just wondering, like, with what you just said and what you think is like BCG, what would you do at this point in time? Would you treat empirically, or how would you treat the situation?
Yeah, I think we had a very similar conversation with last week's RLR about the empiric treatment of tuberculosis. And remember that, the M. bovis is just another form of TB. And so is just another microbiological friend of TB. And so I think that same principles apply. The principle of the difficulties in culturing and the difficulties in confirmatory microbiological diagnosis, and the role of empiric treatment in diagnostic clarity. So I think here you probably are near or have crossed the threshold to, one, of course, get tissue sampling for microbiological confirmation, which you're doing, but then also empiric treatment. And I think that in this case, if you take an analogy of a patient who has a disseminated granulomatous fingerprint with the pulmonary nodules and the HLH signature, and then you say that I know that they have latent TB with their either exposure history is very prominent, or their quantiferon is prominent, or they had a recent exposure, you would probably empirically treat that person. So here I would say that if I were this patient myself, I would definitely ask for empiric treatment, because I think that's the most realistic shot of a diagnostic clarity, with microbiological confirmation being a great added benefit for peace of mind. But you're zeroing in on that diagnosis because you haven't found anything else infectious or malignant. And you also humbly recognize that you may never definitively prove this in a lab, and may have to prove it in the experiment run with the patient themselves, unfortunately. So that would be what I would do. If I were him, I would probably ask Prof. Rez to prescribe rifampin, isoniazid, and pyridium for me. Prof. Rez, your thoughts?
You know what's so fascinating here? It's like, and I only learned this like recently, like how the infection actually gets to the lung dictates the yield of the BAL. Because if we're saying it's from the bladder injecting in hematogenous, it's not going to be in the actual parenchyma for you to isolate when you send your culture. So it's really important to know that and not be dissuaded by an infection that has a tropism for the lung parenchyma.
Agreed. By the way, I misspoke. The Mycobacterium bovis is an inherent intrinsic resistance to pyrazinamide. So your empiric treatment would not be ripe. You would have to probably treat M. bovis more accurately, like the experts in the room know. But that's one fun fact about M. bovis that distinguishes it from MTB.
Folks, I have disoriented Robbie with all the Peridium talk.
Yeah. So just to give the information, I don't know if I said this earlier, the quant from 10 years earlier was negative, but a repeat quant returned positive at this point in time. And after that, on day 30 of hospitalization, the AFB blood culture speciated for MTB complex. And the PCR, which was, I think, sent to the CDC, identified the species as M. bovis. And of note, the last therapy was 2 years prior to this presentation. And the patient was initiated on appropriate antimicrobacterial therapy.
Did we lose Prof. Rez, or did I just not see him anymore? Oh my gosh, Yusuf, this is an absolutely incredible case and very, very humbling, honestly. And you know, the number of times that I've had patients with a BCG therapy and thought about this is very, very low. But I think the real momentum in this case builds when you reported those HLHE labs. And so my advice to everybody in this case is there's so much learning about how you treat a patient who has an inflammatory syndrome in the context of a transplant, how common things are very, very common with the strep anginosus bacteremia, but that kind of nuanced pearl of just treating HLH like you treat the differential, the CBC differential, and that skews you towards different kinds of infections. And it's that gaze that like, oh, HLH, think mono and granulomatous infection. And when you think granulomatous infection, it's really hard not to worry about BCG. So I know that there are experts in the room who can probably teach us much more about that. I'm very, very excited for that. But I think the moment for me that this case finally, like you just got momentum was, oh, this is actually inflammation of the HLH type. And that I found very, very helpful. Prof. Rez?
Yes, I just pulled a Yusuf. I was late to IDR and it just finished, so now I'm back. I think, for me, Robbie, honestly, because like if you never heard, and I don't expect the audience, I would say 99% of people to know about this phenomenon. There's no reason, like unless you read a case in NAGIM, to know that instilling BCG in the bladder can lead to this diagnosis. But if you've been exposed to it, or if you've read about it, then even in aliquot 1, I promise you, both Robbie and myself, we thought about it because we saw an NEJM case. We didn't lead with that discussion, but the mind was prime. And because the mind was prime, Robbie was able to, in aliquot 4, be like, wait a minute, why is there a leukocytosis? This makes lymphoma less likely. Now I'm more worried about a granulomatous process. But it was all through priming of the mind in aliquot 1. And if you didn't know about this diagnosis, don't be discouraged. There's no reason for you. It's very rare, but that's why you come to this report, because maybe in a few years you have a patient like this and now your mind is primed, but 99% of the time it won't be because of that. It'll be because of just a strep sanguinis that resolves with antibiotics and there's nothing more to it.
Yusuf, what was it like? What was your experience like? What did you learn? Take us through the your lens on this.
I think I was lucky that I had a team who let their eager resident do whatever they thought was possible. So when I had the HLH, EBV, I was like, oh, I want to test for HLH. Even though the team did not think it was going to be like primary HLH, but like, oh, please, like go do the workup, because if you think this is it, like go for it. And then we sent the complete workup, and it was just agonizing at that point, or you feel helpless, where you want a diagnosis but you're stuck with the patient getting the fevers, and you feel bad because I want to treat before like having a diagnosis, and that was the tough part. And I was literally going through the literature for fever of unknown origin and going through like every single one and presenting them on rounds. Like, this is the two things that these are the only two things we haven't checked for, but otherwise and this wait time before the culture returned positive, I was texting Wasim, and we're like, oh, the only things that are left possible are either a malignancy that we haven't detected, or bovis or mycobacteria that hasn't revealed itself yet. And fortunately, it was mycobacteria, and the patient actually did well, and they were discharged, and we're following in clinic.
Absolutely amazing, Yusuf. That's just so profound, and I think we all can relate having a similar experience, just the agony of like really worried about something. And in most of those cases, it doesn't pan out, but I'm really glad that your hunches were spot on for this patient. And they took us to where you were able to diagnose the patient, hopefully get them better, and then present it here. I know you have two friends with you who are experts or budding experts in this space. I don't know if Wasim or Varun have any thoughts to add or any wisdom to impart to the crowd. It'd be really cool to learn from you all.
I guess I can go first, and then Varun can correct me. He's the expert. But I'll start with just saying that the patient was lucky to have Yusuf as a resident. It was a really interesting case. Yusuf was like really, as usual, very dedicated and very thoughtful, and was trying to figure out what's happening, which helped a lot in terms of figuring out eventually what was wrong with this patient. I think this patient is like one of those who is like a teaching moment for us in medicine. It's one of those cases where, thinking about the common things and the simple things first remains kind of like the mainstream, I think, of the reasonable, efficient medical thought. But keeping in the back of our mind, as you guys said, that this patient is immune suppressed, that this patient has had a past medical history that involved, intravesical infusion of live attenuated bacteria that is part of the Mycobacterium tuberculosis complex. And so that patient is definitely at risk for that. But thinking first that, oh yeah, they had the strep sanguinis. I actually do think in that context of that patient, it's quite interesting how the intersection of the immunity and where is like the best like sweet spot of where immunity should be in terms of treating TB. Because patients who have TB historically, when they are very immune suppressed, what is their most common symptom is nothing. And this patient, I mean, they die eventually from so much bacilli in their lung that eventually suffocates them. But they usually don't have the symptoms of TB. Actually, those who have like strong symptoms usually have a good immune system. So this patient happened to have had multiple infections, including the strep sanguinis was a real infection. It wasn't like a false flag situation. It was a real bacteremia that made him come to the hospital. And then the first reaction when he arrived to the hospital was like, oh, he has bacteremia. Let's go down a little bit on his immune suppressants. So the reaction was like, oh, let's go down on or Stacra, I think, was stopped on arrival to the hospital. Because anyway, he doesn't have, his kidney function is down completely. And the idea of continuing on Tacro was just to avoid like a hyper rejection episode since his transplant kidney was still in. So the reaction was to stop the Tacro. And then 10 days later, when his immune response started to go up again, now he's having the fevers. Now his immune system is attacking that BCG, which is a Mycobacterium bovis that is like sitting in the vessels around the lung. It's sitting in their bladder. It's sitting in their psoas muscle. It's sitting everywhere. And then now we're starting to see. So the patient did have, I mean, his white blood cell count was 17 on admission, received ceftriaxone, went down to normal. And then things happened again. I mean, like that was like 10 days later. So I think that's important. The other thing is talking about receiving BCG, and I think that's an important point that I learned from this case, is that not all BCG are the same. I'm also a BCG vaccinated person. And I was born in Lebanon, so I received the vaccine as a newborn. And actually, we all learned that quantiferon has to be negative in those who receive BCG, right? But actually, BCG is not the same. Like the BCG that is given in the US for treatment of bladder cancer is not the BCG that is given as the vaccine in certain countries. And that BCG that is given intravesical in the US actually causes the quantiferon to turn on positive and not having, even though it's also a live attenuated M bovis, but it does still have the proteins that cause the quantiferon to turn positive. So having a positive quantiferon should not make you think that this is not BCG-induced infection or this is not a BCG infection. It still can definitely be that. So yeah, I think it was a very interesting one with the intersection of immunity, and made us think and talk about oh, who should be receiving that BCG for bladder cancer? Who should be or who should not be receiving it? And even though as us who receive the BCG as a vaccine as kids, usually if you're immune suppressed, you don't receive it. That rule is not clear regarding, like the guidelines are not clear regarding treatment for bladder cancer. It's actually a relative contraindication if you're immune suppressed to receive intravesical BCG, and that's a discussion between the urology and cancer doctors and the patient. So there are no good data to support safety or not of using intravesical BCG. And I think this is where this case is very important to kind of like start to create a momentum for further studies and bringing further data to see if actually it is safe or not to give it, especially for patients who are transplant patients. So yeah, the data is very scarce. And that's pretty much what I had to say. I leave it up to Varun now to add like his
Yeah, thanks, Wasim. I don't really have much to add. I think, I guess I'll just share some reflections about working with both Wasim and Yusuf on my time on the consult service when we saw this patient. And as you all have experienced, it's always humbling to work with such terrific learners who are so dedicated to working up, these very complex patients and having an open mind and maintaining a broad differential and being very diligent about kind of chasing down multiple different diagnostic pathways. I think as a clinician who focuses in this patient population, I think one of the constant challenges that I face is, Hickham's dictum, Occam's razor, and it is always very difficult when you're waiting for these slow to come back diagnostics to wonder, are there multiple things going on? Can I commit this patient to treatment of just one thing? If they don't get better with that one thing, is that because there's actually two things? And that is a constant struggle on that consult service. But when you have learners like Wasim and Yusuf, it's a delight.
Yo, I don't even know what to say. This is so cool. Wasim, your breadth of knowledge is mesmerizing and really, really cool. And both you and Yusuf, and I know Yusuf is exactly the same. It's really, really cool to see that. I really, really admire that. And on a personal note, it's really cool to see people who were born in Lebanon continue to do incredible things. I feel that resonance with you all. But anyway,
Where are my Iranians?
yes.
Disappointing me. Shame on all of you.
It's because you kicked the soccer ball so far and they don't want to know anything. If you miss Prof Rez is the master storyteller. He shared a great story. Well, go ahead, man.
I was gonna say they're still waiting. Rumor has it they're still waiting for that ball to land, Rabih.
Exactly. That's why they're not here. All right, Ibrahim, please keep us on point and take it away with the teaching points, my friend.
Okay. Thank you, Yusuf, for bringing on this case, and thank you to Prof. Reza and Rabih as well for taking on the discussion. Thank you as well to Dr. Abdullah as well as Dr. Varun for the great teaching points at the end. So I know that there's a lot on the whiteboard, so I'll try to minimize as much as possible. If a patient who is presenting to you is presenting with fever, chills, and rigors, you typically have to raise in the red flag for the rigors because rigors usually indicate bacteremia. If they're presenting and they have a history of transplant, you typically want to evaluate the time or the chronicity since when did they have that transplant. And so typically patients would present with nosocomial infections. If they had the transplant recently, then they would go on to present with immunosuppression-related infections, including CMV, as well as reactivation of indolent infections. And finally, post a certain number of years, they would have typical presentation of community-like infections. If a patient is presenting and they're immunosuppressed, as in they have a history of end-stage renal disease or a transplant, those patients are typically susceptible to certain types of cancer. So you also need to evaluate for them, including PTLD, as well as Kaposi sarcoma and skin cancer. And then you also have to remember that the drugs are associated with very high side effects. The drugs that are used for end-stage renal disease or transplant, including tacrolimus, including increasing in hypersensitivity side effects. And then for the positive side effects, for the positive blood cultures, typically you want to approach blood cultures thinking whether or not these are true positive versus false positive. And the way by which you would determine if they're true positive or false positive is that you would look at the number of blood cultures that are actually positive, the time to positivity, as well as the type of organism. So if it's a gram-negative organism, this is typically a true positive, but if it's gram-positive, then you also need to look at the host as well as the organism that was identified on the culture itself. And then also remember, if a patient had an AV fistula or an AV graft, that you need to differentiate between the two, because grafts may be a nidus of infection. And then if a patient, again, is presenting with constitutional symptoms, you need to look at the blood pressure, especially if they had a prior diagnosis of a valvular condition, because a wide pulse pressure may hint towards a valvular insufficiency, or a blood pressure exaggerating the pulse pressure itself, or a vascular sclerosis if they had a history of end-stage renal disease. And then also you need to think about granulomatous infections in patients with end-stage renal disease, especially considering that this patient had intravesical BCG for the bladder cancer that they had years ago. And then when you evaluate this patient further with a PET-CT, you need to look into the specific FDG avidity sites and think about them as metabolically active sites. So they might not be entirely related to infections, but could also clue into cancer. The way by which you would differentiate between both of which is you need to look into the nodularity itself and whether or not you can identify a primary source. If you can identify a primary source, this is typically cancer. If not, and the patient is again presenting with a typical picture of infection, you need to raise your high likelihood ratio for an infection, and maybe you need to treat empirically if this patient was presenting with a history of intravesical BCG and you're suspecting TB. And then also remember that if a patient is presenting with a typical picture of TB, M. bovis is highly resistant to pyrazinamide, so you may have to consult ID, and you may have to adjust the LIPE therapy regimen. And then finally, this was a TP that was actually shared by Dr. Abdullah, that patients with end-stage renal disease and TB will typically present asymptomatically. So you need to suspect activation, immune activation, if they're presenting symptomatically. And then you also need to consider the safety of BCG if they present later on with bladder cancer, or if another patient who had no history of such an infection is presenting with bladder cancer that you need to treat. So I think that's all. I hope it wasn't much.
Oh, Brandon, that was incredible. I think the task of capturing the learning points from me, Reza, Wasim, and Room was no small task, and I think you did that extremely well. Thank you so much. Thank you, Yusuf, for an amazing case. Prof. Rez, I hope your PCP finds another job and is doing well. I can't let go of it. Have a great day, everyone. Are you playing something?